Hey everybody, let's talk about probably the most important thing you can do as a sleep technologist, which is to take proper documentation. Without it, the patient doesn't stand a chance against the subtle nuances in personal situations. Without documentation, you might not know what kind, type, or size CPAP mask the patient wore, or what the patient did throughout the study, and other key elements of the study. There are three components to successful documentation: keeping a medical record, providing medical documentation, and charting. Charting references demographic information about the new patients, interviewing patients and filling in medical history forms, recording any procedures performed, and recording notes throughout the study. All of these are directly imported into the medical record. Individual notes and documents that healthcare workers add to the medical record are called medical documents. The entire collection of documents that are filed together and form a complete chronological health history of a particular patient is the medical record. The infamous quote about documentation is if it isn't documented, it didn't happen. Absolutely everything the provider can't see from the raw data should be documented. And then even some of the stuff they can see. In case of an accident or a patient sues a practice, your documentation could be the difference between the lab shutting down or staying open. Medical records are legal documents that can be used as evidence in court. Documentation shows proof of what actually happened. Documentation is also part of regulatory agencies. It ensures that policies and procedures are standardized and protocols are appropriate for the setting. Participation in certain programs like Medicare require specific documentation guidelines to be followed. It can also improve cost control. If there are patterns in the sleep studies where it is noticed that a study could be more run efficient just based on notation, it could save the lab money. Proper documentation also shows insurance companies that everything is in order and the lab does the right thing to get their patients processed. It's hard to get the insurance companies to cover anything without documentation. When the referral process begins, there are certain pieces of information that need to be communicated between providers. The referral depends on all the requested information be provided to start helping the patient. Without it, procedures can't be followed. Each entry needs to be signed physically or electronically. Like lawyers, you only need to state what is applicable. Don't go out of your way to find information on a patient that doesn't relate to your specific scope of practice. When the patient speaks and you need to keep when the patient speaks, you need to keep those words and document them in quotation marks. To make sure there is no paper contamination with other patients' information, the patient's name and identifying data should be on every page of the referral. It absolutely must be legible so everybody can read it. As with anything important, you need to use your best English skills when documenting. Spell things correctly, use proper terminology, good punctuation, and grammar. When the referral comes in, the provider needs to know what the patient is coming in for. So the referral needs to state the problem and what they're trying to get accomplished. Make sure the important details are also noted. No duplicate reports. If there was one study, there should only be one report. Avoid using abbreviations. A lot of techs use PT for patient. Uh, but they can mean so many different things. EDS, for example, can mean excessive daytime sleepiness or Ehlers-Danlos syndrome, which are two very different things. One causes the other, though. Occasionally, some entries are put in late, and that's normal. Like sleep study reports, for example, should be filed on the date that it was run, but the report usually takes a few days to complete. It is retroactively added in just by changing the date of the entry. Documents have to be signed by the proper person. Certain documents require a provider's signature, some might need your own. You should never sign for anyone else other than yourself. That can complicate things in a huge way, even if you're trying to help someone out. They may not have the same intentions or might document things a certain way. Also, recording false information, signing for someone else, is a serious offense and should never be done. Don't leave additional space. This really applies for paper documents, which is mostly antiquated. But if you do that, you don't want other people adding information erroneously behind you without you knowing it. It could jeopardize your job. It's kind of like if you even write checks, you write the line through the rest of the space so that they can't add money to it. You should never chart anything in advance because what if the patient never even makes it to the lab? It can also lead to confusion if others have taken over the case. If writing on paper documents, write in pen with blue or black ink and complete everything when it needs to be done. It's important to keep the original mistakes because someone may need to know why documents are put in retroactively or things were done differently. It can also show that a deadly mistake was made because they can read over the stricken record, but not if it's covered up. Someone might have just read your document about trying an injection of insulin, but you meant to put that in another patient's chart, but now it's too late and someone else gave that patient those drugs. At least they have a record when you crossed it out and dated and initialed it, plus whatever the policy and procedure manual requires. Some P&P manuals use the abbreviations for ME for mistaken entry or just write correction of error. Just use a single line strike through. For the purpose of reading it again later, don't use correction fluid like whiteout. If you're typing on a word processor, you can go back and fix errors until the document is charted or printed. Then you have to follow the strikeout rules. We use military time to document sleep study events so that we don't get confused about which 7 o'clock the patient got up and on which day. Military time is expressed in just 4 digits, and instead of o'clock, we just say hours. It accounts for all 24 hours in the day. If it's daytime, which we would consider 7 a.m. to 7 p.m., or we would say 0700 to 1900, and nighttime hours 1700 to 0700. If the time is also at the top of the hour, like 6 p.m. or 7 p.m., just like we would say o'clock, we would say 100 hours. For instance, 6 a.m. would translate to 0600 or 0600 hours. To account for PM hours, we add 1200 to the 4 digits. So the example is 1200 plus 0100 for 1 p.m. equals 1300 hours. Or you can just continue the number in the sequence. 12 p.m., then 13 is 1 o'clock, 14 is 2, 15 is 3. If there is more than just the hour to note, like 7:15, you would just add 12. You would just add the 1200 to the 700 to get 1900, and then add 15 to get 1915 hours. You wouldn't say 100 hours. There are many ways to organize medical records, and this is an example of a source-oriented record. It's broken down into sections and separated by tabs. If you can, imagine an application that has buttons, one for each of these items, and that's where you can access each of these kinds of documents. History and physical keeps documentation of the patient's medical past and a record of their annual physical results. There is a place for all the physician's orders, past and present. Remember, things in the chart don't go away. They are just documents that stay within the record. It's important to recognize which orders are from or for a specific date. Admissions regards all the forms and consents that deal with the intake process into a facility or hospital. Keep in mind the patient might have a few medical records. Think about all the places you've received care. Did all those places send back reports to your primary health provider? Maybe not. Some referrals do send back reports for PCP records, and that's how it should be. Your doctor needs to know everything that's going on with you. So you will have documents from other labs and other doctor's offices in the patient's record, most likely uploaded into the chart by one of your lab staff, which they would sign. Diagnostic tests will include the physical or digital documentation of all procedures performed in the facility. Surgical procedures are needed for an emergency basis. It also may affect the physician's opinion on certain sleep disorders. One sleep pearl I remember was a gentleman who was on CPAP for many years, but all of a sudden his CPAP compliance downloads were showing a horrible increase in sleep apnea. After a consultation and history review, it was found out the patient had a spinal fusion, and something about the anatomy was then situated and made the sleep apnea worse. So graphics include charts by charting software to indicate trends on blood pressure and weight. Flow sheets are forms for specialty needs like monitoring blood sugar, or dental forms that monitor teeth conditions over time. They can also include treatment or therapy options in succession. Medication history is crucial for a provider to make the best decisions for a patient. Again, if the patient is on a million medications from 100 different providers, it might be hard to include all of them. Every time a patient returns to the facility, or every time a patient changes a medication, it has to be documented. Medications can have serious side effects if taken in excess or completely stopped. Doctors could also prescribe medications that have harmful contraindications for mixing other prescriptions if they don't have a complete medication record. Unfortunately, some people turn to prescription dispensing providers to satiate their own addiction or to sell on the black market. That's why we have the DEA. That's why the DEA has a registration that providers can keep track of what narcotics or other high scheduled drugs have already been prescribed to a patient. Progress notes should include updates and findings each time the patient goes in for a follow-up, as well as a care plan for the patient. Forms should always go into the designated section and filed chronologically. You have to be careful to import it based on the date of the record or documentation and not the date that you're actually importing it. If there are paper charts, the most recent documentation goes on top. When a paper chart becomes too full or thick, with so many files, old documents can be moved to another folder with a note placed in the main chart referring to the additional documents. This is also known as thinning. For HIPAA, never leave charts out where people can just look through them, and don't leave your computer screen open. A lot of these are the same kinds of sections you would see in a primary care provider's chart like we just saw, but the sleep patient's chart adds a few extra things that are specific to sleep charting. The medical history should be detailed, include personal, familial, and social parameters like do they smoke, do they use street drugs, do they drink alcohol, what's their family or relationship at home like, if you work, what do you do and do you like it, stuff like that. Personal history should include the patient's past medical problems, surgeries, allergies, current problems, assessment of each body system, and a review of past and current medications. It also may include suspected diagnoses and a plan for further assessment and treatments. Sleep questionnaires will include the Epworth Sleepiness Scale, pre-sleep or bedtime questionnaires, post-sleep or awakening questionnaires, and sleep diaries. Technologist notes, either from the sleep study or separately prepared by the technologist, regards incidents or patient comments, notes about medications, or anything. Uh, Normal or unusual, that is. Scored data will have reports from previous sleep studies that have already been processed. The sleep lab has a few consent and confidential. It's got a bunch of confidentiality agreements like HIPAA, consent to treatment, consent to filing insurance and payment, consent to video recording, and consent to access provider files, PAP therapy consent. There's a lot. So diagnostic tests will have any reports that include findings obtained in an attempt to diagnose or monitor the progress of the patient, like EKG. Uh, if the patient came in with sleep apnea and a heart arrhythmia, maybe the patient doesn't have the arrhythmia anymore after treated with PAP therapy. Progress notes will detail any follow-ups like provider follow-ups, follow-up from the DME, stuff like that. Different charting software organizes charts in different ways, and these are all hypothetical sections, but they're most likely to be seen in charting applications. Unlike previously mentioned source-oriented charting, problem-oriented charting organizes everything around the patient's health problems. It's a it's a totally different way of organizing a chart. After an initial assessment, a list of problems and related plan of care are identified. After this, all future documenting refers back to this list. New problems are added to the list, and fixed problems are documented as resolved with a date. Let's go over SOAP. S stands for subjective. It's what the patient thinks going on with them. What are their complaints? How are they behaving? Does their behavior accurately match their symptoms? Subjective also includes significant patient behavior, like if they miss a lot of appointments or fail to follow directions, statements of dissatisfaction regarding treatments, failure to pay the bill. Objectively, tests are run to find out what the actual problem is, usually with patient complaints first being explored. A is for assessment, which is the professional opinion of what is wrong based off of visible signs and testing results. P is the plan that the physician has crafted for the patient's future health goals, including procedures, treatments, and patient instructions. Narrative charting can be difficult to read and interpret in the end, but a lot of providers like psychologists or social workers will use a narrative form of charting to keep detailed notes on all aspects of care. Narrative charting uses the healthcare worker's own approach to describing the patient and care provided, potentially giving a potential sway or bias of their thoughts towards the patient's condition. Because everything is almost a stream of consciousness document, it can be hard to find specific events or documents. Nurses are known to have used charting by exception practices to document what is currently abnormal about the patient, especially in the hospital or emergency room setting where data needs to be accessed quickly in case of an emergency. It requires the provider to understand normal findings in testing and to what severity those abnormal findings can express. Because of the spontaneity of these kinds of facilities, they usually do not include preventative and wellness aspects of care, especially if they are not performed in the same facility or setting. Like everything in life, computerized charting comes with its upsides and downsides. Advantages of using a computerized charting system, also known as an EMR or electronic medical record, include easy to read information if it's typed. It can decrease time spent physically charting documents and cost of paper, storage, and clerical staff. There is also an improved communication between providers because you don't have to try and find a chart. You can access it from any computer that has the capability. On the other hand, there are people who take advantage of security flaws to illegally search and copy medical records, causing confidentiality breach. It can also be expensive to either purchase or subscribe to an EMR service. As with all electronic devices, no power equals no information, and that goes for the mechanical aspects of computers as well. They do break down. That's why there are redundancies or backups of sleep studies and sensitive information, and a lot of sleep labs have backup batteries equipped with their monitoring stations to ensure no data is lost during a recording. As the study records, you have certain buttons that you can press to insert a comment onto the sleep study record itself. During the study, the technologist enters comments as anything of note happens. Some providers require you to comment in the O2, the sleep positions, the sleep stage, and time every 15 minutes. But that's usually just to make sure you're paying attention to the patient. But the provider should already be able to see all that information they're reading, so why double the comments? Better yet, the technologist needs to note things like when the patient rolls to a new position, when the patient leaves the room for a bathroom, when they come back, when a wire falls off and the patient has to go in and do something about it. Document the snoring intensity. How loud is it on a scale of 1 to 10? Document the CPAP pressure if there's a leak. If there's a big storm and thunder's waking up the patient, or if the patient's phone wakes them up, there are a million things that you can document. Even if there's nothing interesting happen, you can always comment something like the patient appears to be sleeping quietly on their right side. Sometimes the sleep software will even have little hotkeys or buttons that you can press to insert a pre-written comment like wake or TIR, which means tech and room, or right side. It may be determined upon the policy and procedure manual as to which notes are appropriate and what the provider doesn't care for. Take your time with documentation and reread it to make sure everything makes sense and it's understandable when someone else reads it. If you make a comment by mistake, just put in another comment right after explaining. I can't say enough about documentation, and you can take it from me. I've been praised by several of my supervisors and providers who I ran studies for because of my ability to communicate what I was thinking during the study. That's what they want to know. Why is this sleep tech doing this or that? What are they thinking about? If you give them documentation, then they'll know. I personally wrote a brief introduction for every sleep study I ran, and I would put it in the beginning of the study. Right after lights out, I would write something like this. This is an MPSG for a 36-year-old male who presents to the sleep lab complaining of snoring and headaches for the past 6 months, in his estimation. He has comorbid conditions of hypertension and anxiety attacks. He has certain medications that were taken just before bedtime, which is when he normally takes them. He has been educated on CPAP therapy and is interested if he qualifies. Anything to help my dog sleep better at night, he says. Uh, so I would pretend like I was a doctor explaining to whoever read the study what the study was for and why I did the things the way I did. You never know when access to medical records is not available, and a brief summary is helpful to remind the reader what's going on. If I couldn't scrub their skin on their legs because they were diabetic and had poor skin, I would enter that into the beginning of the record where the impedances are recorded. I would also include whatever interesting events occurred before lights out, like if the patient had some drinks and as they might before bed, or were tearful because they were anxious about the study results. All these factors can have a big influence on the results of a study, and it's important for them to be documented because if it isn't documented, it never happened. That's documentation. We've got one more part, and we'll be done with Unit 1. Please email me or text me with your questions or comments. I'd love to hear from you. See you next time.